Hello, my name is Ciara with Welcome Family Senior Solutions, and I have...
My name is Mo, and I am with Savior Hospice and Palliative Care.
So we just wanted to get together and talk a little bit about Alzheimer's and dementia, what the differences are, just some other questions that we feel like we get a lot from people.
We do, yeah.
So you actually do training on this with, is it families or what do you do?
So great question. So I am, besides working I'm a patient advocate for Savior Hospice. In addition to that, I'm a certified dementia practitioner, and I do educate memory care facilities, family members, caregiving staff, anybody that works in a memory care facility or even in an assisted living, maintenance, food servers, housekeeping. Everybody should be educated on, some of the do's and the don'ts of dementia care.
Yeah. And that's, I think, really important because some people think it's just the families and just the caregivers.
Yeah.
But really, the cooking staff, the cleaning staff, everybody is part of the care.
Exactly.
And can make a good environment or make an environment that's a little bit more uncomfortable for the residents. So it's important for everybody to know. Good to know.
Yeah.
All right. Well, okay. So we have 5 questions here.
Okay.
We're going to start with, there are many that feel as if dementia and Alzheimer's disease are 2 different things. So can you explain this?
Yeah. So we do, usually when I do my dementia presentation called the do's and don'ts of dementia care, I come right out of the chute asking the question, can somebody tell me the difference between Alzheimer's disease and dementia? And then I follow that with wrong answers only. And people will begin to start telling me the differences, what they think the difference is. Some will reply back that Alzheimer's might be more advanced than dementia, that dementia may be more advanced than Alzheimer's disease, when really the case is that dementia is the overall umbrella, and Alzheimer's disease is the most popular dementia. So Alzheimer's disease is the most well known, and it falls under the umbrella, the category of dementia, along with other dementias. So we have several dementias out there. It's kind of like cancer. There's not just one cancer. There's several types of cancer. So Alzheimer's disease being one, Lewy body dementia being one, the great and hilarious comedian Robin Williams was diagnosed with Parkinson's disease and Lewy body dementia. Frontal temporal dementia is another type of dementia. And then there's alcohol and drug related dementia. There's vascular dementia, which is typically caused due to strokes and any vascular challenges that patients may be having. And that is really the tip of the iceberg right now with the different types of dementia, Alzheimer's being one of them.
Okay. Yeah. I think that was a really good explanation because even as professionals, there's so many people that don't know really the difference. They just kind of lump them together.
They do.
Rather than separating, okay, this is, do you feel like you would address the different dementias differently, or is it kind of similar with?
That's such a great question. I think so. I think there's different types of dementia that cause you to struggle with your verbiage and struggle putting words together, word salad. I am not clinical, so I'm just going to talk like somebody who's not clinical. Okay. But there is word salad, right? Yeah. And I know there's a clinical term for that, and I won't say it because I'm not a nurse. But as far as helping somebody along with words that they're trying to put together is always helpful. There's other types of dementia that cause you to hallucinate. And how are we going to treat that patient, that resident who is hallucinating? And what different types of non-clinical therapies can we use to help them? But yeah, I think there is different ways that we can use, non-clinical people can use therapies to help alleviate some of the symptoms, mixed with a really good clinical team, of course. Yeah.
Okay. Yeah, I think that that's a key point, mixing the two. So that way the non-clinical can definitely know what to look for, how to address things.
Yes.
Because in assisted living homes like this, there's most are non-clinical. There's a lot more homes that are getting more nurses now, but
they
overall, there's not a standard of having nurses work in the homes. So it's important for everybody to understand that, depending on which type of dementia they have, they're still going to have to address the person as an individual because they're going to have different issues.
Exactly, and I think the symptoms are what our PCPs and our providers are treating symptoms now, depending on whatever the symptoms are. So
yeah.
Okay.
Question number 2: what is the stigma around dementia?
Well, I mean, for me personally, I can't tell you how many families that I run into, because in my business under hospice and palliative care, I go out and I try to find people that need help with hospice and palliative that have advanced dementia. I remember when my grandma lived with us when I was little, when I was about 12 years old, 10, 11, 12 years old, and it was called one word. It was called senility. And grandma senile, and the word senile became a terrible negative stigma on people, that because they really didn't know what was going on back in those days. So there's a negative undertone when you have dementia, and I'll run into families that will want to hush that their loved one has dementia. So they don't want us talking about the dementia in front of their loved one. But I'm here to say we need to start talking about it in front of them, because a lot of our loved ones that have mild to moderate dementia or even advanced dementia don't really understand what's going on. They know something's wrong, but if we're not talking to them about it, why would we expect them to not have any form of behaviors? So if we can put a name to what's going on for them, I think it's very helpful. If we don't feel comfortable using the word dementia with our loved ones, I really believe it's important that we sit down with our loved ones and explain to them that they are living with the challenges of memory loss, that they can't help it. And I really think it helps with negative behaviors, for sure.
Yeah, I think that's really important, like you said, to give it a name, because then it's something you can actually work on, and it doesn't really even matter what the name is, as long as they can address those, find the skills that they need, or talk to whoever they need to be able to find the tools to work through their journey.
Yeah, I think it's because it's the mind, right? So if your loved one has cancer, if they have kidney disease, end-stage kidney disease, or end-stage liver disease, or if they have end-stage cardiac disease, we're not going to hold that from them. So why are we holding memory loss as something to hide? And we need to remove the negative stigma around all forms of dementia. It's something that we cannot help getting. It's a disease process.
Yeah.
And right now, I believe 50%, that's 50% of the people over the age of 85 have some form of dementia. So we should stop hiding it.
That's a good point. I feel like a lot of the seniors that are in early stages are having trouble with thinking that can't be them, So I think children, and not children as in young children, but their adult children
kids,
are having trouble, like, saying, yes, you do have it, So just finding, like you said, maybe a different word, like memory loss, or that's not as harsh as of like, okay, you've had this diagnosis, but you're giving them at least, okay, there's memory loss, we can work on this. There's puzzles, there's games, there's interactions, there's a lot of other things. And I'm glad you brought
that up, because it's not a perfect science. You can use memory loss, you can use dementia, and there are going to be a percentage of those living with dementia that are still going to deny that they have it to their adult children. And we can talk a little bit later through these non-clinical therapies that we're going to talk about on how to handle that sort of thing.
Yeah. So I feel like it definitely is a family dynamic that would determine, then that's where the clinical part of things come in, because then you can offer suggestions or resolutions on how to get around some of these, like you said, stigmas, where it's just, unfathomable. They won't consider that as an option.
Yeah, I hear all the time, oh, my mom's horrible disease, this disease is horrible. And it has such a negative undertone, but really mixed with a really good clinical team and some non-clinical therapies, we can really, really make a difference in the lives of those living with dementia and our lives a lot easier. And the reason why I even began this journey with dementia is because my mom at 89 years old had nothing wrong with her, just healthy heart, healthy lungs, no cancer. She developed dementia and eventually passed away from it after living with it for years and years. But it wasn't until I started agreeing with the disease instead of fighting against it did our lives start to change.
Yeah.
Yeah.
I think that makes a big difference in how you guys can still enjoy the process, in a sense.
You can enjoy the process. It doesn't have to be horrible.
All right. What are some holistic ways we can help with those living with dementia?
So I don't know if anybody has ever looked up Naomi Field. She is incredible. She actually passed away last December at 92 years old. She's an American social worker that developed validation therapy. I actually got my validation therapy certification under her at an event that I attended. It really is self-explanatory. Validate, validate, validate. So it's in our human nature to argue when people are wrong.
Yeah.
Okay. So if mom comes up to you and tells you that the sky is purple with green stripes, we're going to correct her because the sky is not purple with green stripes. The sky is blue. The sky is blue. And it's our human nature to try to explain to mom. Now, this is kind of a ridiculous scenario. It's just an example of some of the beliefs that people with dementia have. So if mom tells you that the sky is purple with green stripes, what would it hurt, seriously, if we just said, okay, and we stopped arguing with things that don't matter? It doesn't matter that she thinks that the sky is purple with green stripes. It just doesn't matter. Yeah. So we have to stop arguing with those that have dementia. We have to stop proving them wrong, even when they're wrong 100% of the time.
Yeah, I don't think it's as important to reorient them about things like that. I think when it comes to danger and stuff like that, then there's more of the redirection, but you're still, like I've had residents that were like, oh, there's a big hole in the ground right there. And then we're like, okay, well, we better walk around it, Exactly. And it's very much not like, I don't see a hole. What are you talking about?
Exactly.
Because then he'd be like, it's right there. You don't see it. And then he would lose that trust in me. That's right. I didn't believe him, or if I didn't, he would just be like, oh, you just think and they'll be like, you just think I'm crazy. I'm not crazy.
And I like what you said about the danger piece. So we have a rule of thumb, right? So if it's not hurting your loved one physically, if it's not hurting somebody else physically, and if it's not draining their bank account, then agree and validate. Yeah. There's really no reason not to. I can promise you, when you begin to agree and validate with your loved ones living with dementia, it's going to change your world. It really is. Yeah. Yeah.
I really do feel like, too, when they do build that trust when you just believe them. Because I think even to a sense, they know that that's like a purple with stripes. Did you see that? And right. They'll ask you, and then they'll look at you, and then you're just like,
And I have asked folks that are hallucinating, do you know that you're hallucinating, or do you really believe that you see it? And 9 out of 10 times they'll tell me, I know I'm hallucinating.
Yeah.
Yeah.
So, but they definitely want to feel validated. They don't want to feel
That's
like they
right.
have that memory loss, and they don't
Yes.
want to feel like they have, you know, to deal with something that other people aren't around them dealing with, like their children or their family or friends. Or so to just be accepted, and then, you know, like you said, out of danger, then that's a good
Yes.
foundation, you know. So then as they start to have more decline or, you know, troubles, they're able to know that they're going to feel comfortable, because that muscle memory is there. They will feel comfortable with who is validating them and who is not.
That's so good. That is exactly spot on. I love her. I don't know her name. I don't know who she is, even though she's been my caregiver for 5 years or whatever the case may be. But I do put together that this person validates me. Now, of course, divert is the word of the day. Divert, divert, divert. Patients that are, because it seems like people with dementia are fixated. They get fixated. They seem to come to, and I don't want to use OCD in a clinical way, but they do seem to get into
have repetitiveness behaviors or movements. Or...
Yes. So of course, diverting is the right thing, but how are we going to divert? Just saying, come on, let's go move over here isn't to avoid the hole, you know, isn't always, but there's a hole. Aren't you worried about the hole?
Yeah.
So if we begin to use another non-clinical therapy called, again, it's so self-explanatory, called reminiscent therapy, and just begin to talk about their past. This is why it's so important. If your loved one is living in a group home, any sort of assisted living facility, that they know the history of your mom and your dad or your aunt, your grandma, their past, their what they did for work, places they've traveled, military, things that they collected, sports they like to play, anything that you can think of that will bring them back to a place where you can begin to reminisce with them. So while we're avoiding the hole, Mr. Jones, tell me about your time in the military. Oh yeah, I was a sergeant, and the next thing you know, they're on that topic.
Yeah.
So validation therapy, therapeutic fibbing, which is kind of a therapy that has been a little bit controversial in the senior healthcare field, but reminiscent therapy as well. And we could touch a little bit on therapeutic fibbing if you want.
Yeah, like let me know a little bit about that.
So there's some people, and I have the greatest respect for those that don't like to use therapeutic fibbing. So I don't want anybody to misunderstand me. I find it very helpful in some scenarios. We have Mr. Jones, who just got moved into a memory care facility, and he's pacing the floors, and he's panicking because he can't get out because he's in a secured memory care, and he wants his money, he wants his checkbook, he wants his car, and he wants to go home. And us saying, you are home, probably isn't the best answer. You and I talked about this before. But if he's fixated, like we talked about earlier, about where's my car, instead of saying you can't have your car here anymore, you don't have a driver's license anymore. And depending on the patient, so this is always to be determined. What if we just to get them to relax a little bit, maybe try, your car's in the garage, they have your keys, see if things like that would work. Take me to the bank. My daughter's trying to steal all my money. That's a big one. My family wants all my money. What if the caregiver instead said, you know what, today's a holiday. Let's check the bank tomorrow. Maybe the bank will be open tomorrow. Now, this doesn't work 100% of the time, and that's why I feel like there's so many people that are against therapeutic fibbing. But as caregivers, as people that love those with dementia, we kind of have to know our audience when we can use it and when we can't use it. I have been called out by somebody with dementia before who, wanted me to get her dressed and and get her ready for her daughter to come pick her up. And I told her daughter was running late. She'd be here in a half hour. And let's get you a snack. And I'm telling you, 30 minutes to the minute, she was like, where's my daughter? You said 30 minutes. Yeah. So, I mean, we do have to really know our audience and be sure that we're using therapeutic fibbing lightly. But it absolutely does work. And we're not lying for any malicious reasons whatsoever. It is not malicious. It's to ease the suffering of whatever that they're fixated on. And that's quite the difference.
Well, I think we had talked about that too, that no matter what people do, it doesn't matter if you have Alzheimer's or not. Like, if you're having anxiety, that doesn't feel good for anybody. So if anxiety is causing, because of this confusion of what's going on, then, you have to safely find a way to de-escalate that, because we don't always want to jump to medications either. So if there's skills like this, like the fibbing, and sometimes I've even done it where there's a couple of times I've had to do things like that and it worked or it didn't work. They might just be like, no, she needs to be here now. And then you're like, okay, that's not the one I'm going for. Then let's try something else. So then it's the snack or your favorite show's on or whatever, But I really do think that every person, even though they might have Alzheimer's or dementia or whichever form, they all still have very different things that they're attracted to. You just really individualize it, and there's all these things that are available, so you can find what works. I mean, if we only had one option, then you know what I mean. And if everybody was closed off to some of these options, then the quality of life for their loved one's going to be harder. Their quality of their time with their family members is going to be harder. And people have a lot of anxiety about that as well. Like feeling like they have to be a certain way to their parents or their loved one. And then they, end up not messing up, but having a harder time.
Yes.
Working through it.
And you're right about that. I've run into a lot of adult children who lied to their parents all through grade school and high school, and they're not about to lie now. And I'm trying to convince them that it's okay. If she wants you to take her to the bank because she thinks you're stealing her money, of course you want to, get down, to ground level to your loved one, tell them that you love them, and that you would never take their money. But that is a big challenge that I run into in my field, that paranoia and thinking that loved ones are either want to take their house and move them into a nursing home. This is what you hear, right?
For sure.
So to tell them that you love them, but to also just use some of these validation techniques. And if your resident sees a hole and you're agreeing that there's a hole and you're walking, that's a little bit of therapeutic fibbing too, right? Mm-hmm. Agreeing that the sky is purple with green stripes is a little bit of therapeutic fibbing as well, because we're not correcting them. So these things really work.
Yeah. So, question number 4, how important is a clinical team?
So I'll tell you what, if you want your loved one in their sweet spot with dementia, get behind your clinical team. Trust your clinical team. Trust your nurse practitioners, your medical doctors, the nurse in the building they're in, the nurse in the group home they're in. You have to trust your clinical team. They're not going to nail it usually the first week, but they do have to find the sweet spot with medications. So dementia does cause a lot of negative behaviors. So with non-clinical therapies mixed with a really good clinical team, as far as I'm concerned, is the perfect recipe. So I don't think just medicine works. I don't think just non-clinical therapies work. But I'm telling you, when you mix the two together, you marry them together, I see huge changes. I do run into a lot of family members that are fighting against their clinical team, not trusting their clinical team. I have heard words like, I don't want my mom sitting in a corner drooling. Those things are not going to happen. Your clinical team knows what they're doing. They specialize in this sort of thing. And I always say, please trust your clinical team, and then trust that people like myself are out educating on the non-clinical therapies to help alleviate some of the struggles that your loved one with dementia is going through.
I think some of those family members too really, like you said, need to find the right clinical team for them. Because if they've had a situation like that or have heard of a situation like that, that's usually because there hasn't been good communication between the two. But if you have good communication with your clinical team, they're going to inform you of med changes. They're going to inform you of, new behaviors that are starting. They're going to inform you of, triggers that the resident's having with certain things, adverse reactions, all of that kind of stuff. So that way you're aware of it and not taking it personally. Because I think too, when families come in and then their loved one all of a sudden is mad at them, but they were just asking them to bring in some fries, and they bring in their fries and are like, give me my fries and go. And they're upset. But it could just be a med change. It could just be a new roommate that came in, or they're, wanting them to go out into the main area, but maybe the main area is overstimulating for them. So
it's not a fix-all. It's not a fix-all, but I am seeing more and more in my genre of senior health care, hospice, palliative care, that families really are struggling, and it's not anybody's fault, and I cannot blame them. But I am saying we sometimes as family members have to take that leap of faith and trust the clinical team. But it's hard. It's hard. And it's not magic. I mean, it's not a perfect science, but it's a really good, perfect combination when you mix a really good clinical team and communicate with your clinical team. It's okay to ask questions, pick up the phone. If you can't get in front of your primary care provider, get in front of the medical assistant or the med techs or the directors of nursing or, the group homeowners. Get in front of them and start asking questions and share your concerns. I can tell you that the clinical team wants to know what your concerns are. This has just been my experience. Because
if you're leaving and you're not feeling comfortable because, those hard questions weren't asked, then, you're not going to feel comfortable while you're gone. And then you're going to be feeling the anxiety and the stress, and then when you come, it's like you can't sit and actually enjoy your loved one because you're just too busy trying to fix things. And that's what the care team's there for, so that way you can take the time and enjoy what you've the time that you've got.
For sure. But we want to that's I love that you said that. We want to enjoy the time that we have left. So it really is all about just the quality of care that our loved ones are getting. It really is.
But I do think it's great though that you provide that service. So if they do come in with your team, they at least get the education. They get and because not all clinicians know everything. We're always learning from each other all the time.
Sure.
Even though we all have our different venues we've taught in or learned in or.
Okay, good point. That reminds me then, if you're seeing changes in your loved one, it could be that the primary care physician may have missed it or anybody from the clinical team may have missed it. This is why it's so important for you to communicate with your clinical team on any changes you see. Same with the care staff. It's important that everyone, it takes a village, right?
Yes.
So everyone is constant communication about any changes, the positives and the negatives, and then one step at a time. I always say we have this great big ocean. We have to gulp it one step at a time, and eventually we'll get there.
Yeah. Good. Okay, number 5. So we got, can you explain the importance of validation therapy? We'll touch on this a little bit.
Yeah, we did touch on it. So I'm going to just drill the point home with validation therapy. To me, validating your loved ones with dementia and stopping the arguing and the disagreements, which is easy for me to say, but I can tell you that with my mom, we kind of had an estranged relationship anyway, and then to add dementia on top of it, just it was terrible. Our worlds were rocked from me constantly arguing with her. It wasn't until a medical assistant pulled me out of my mom's doctor's office and grabbed me by the shoulders and said, "You have got to stop arguing with your mom. You have got to you have to start agreeing with her more." And I'm like, I never agreed with her before. Why would I start now?
Right.
But the minute she said, "Go home, start educating yourself," and so that's what I did. When I stumbled upon validation therapy, it was a game changer. I encourage everybody to Google validation therapy. You'll see lots of articles on Naomi. I'm not sure she pronounces it File or Feel, but it's F like Frank, E-I-L, Naomi, Feel. And just start educating yourself on validation therapy. I really think it'll be a game changer for you.
Yeah, there's so much information out
there.
There
is.
And, like you, there's so many specialties in, with it being such a large umbrella. There's so many different, and again, you just can't compare yourself. I do have like a family member that always compared themselves to like Jamie Foxx, and I was like, well, but you don't know what the whole picture is. It's not probably just dementia. It's probably a couple of other things, going on. So,
and you can have mixed dementia. You can have vascular dementia and Alzheimer's disease. You can have Lewy body dementia and frontal temporal. So there is mixed dementia. You can have more than one type of dementia.
So it's really just treating the symptom itself. If they have confusion, or if they have hallucinations, or, you just kind of address those couple of things in their care plan or whatever they're doing. And with that, I mean, they live really good quality lives.
That's the goal.
Yeah, for sure.
That's the goal. So we want to be able to walk into the room and be happy to see our loved one.
Yeah.
We're going to validate the ridiculous things that they sometimes say. Just stop arguing and agree instead. Don't shame anybody living with dementia. When you say things that shames them, then they're going to have a negative thought on you. Yeah. So shaming is another terrible one. This is the hardest one to remember, which is funny because it's about remembering. Try to stop saying, "Don't you remember? I just told you that. Don't you remember?" You'll do it 20 times and then remember not to say, "Do you remember?" And then you won't do it for 5 times. Then you'll do it another 10 times. It does take practice. Try hard to not ask, "Don't you remember? We just talked about this," because they can't remember. And that's it. They just can't remember.
Yeah. I think that was something we had mentioned too before. Like, people try to say, "Oh, they're like children," but they're not like children, because children can learn. And with them, like you said, they can't remember. So it's not about teaching them to remember. It's about just setting up their home, setting up their environment to be able to help them get, remember things, like if there's pictures, or,
that's right.
Once they're further along, and they, I've had residents that need to put the names large on the door, and across the way put "not your room."
I love that you're doing that,
because they would always, when they were at home, they actually would come out of the living room and make a right, and that's where their bedroom was. So when they moved in here, they had to make a left. Bless you. They had to make a left, and so in their mind, they couldn't figure out how to make a left.
Yeah.
So when they'd make a right and they'd see "not your room," then they were like, "Oh, okay," and then they would kind of recognize, just like, "Okay, well, then they would be able to ask, 'Oh, there's my room.'"
I love that.
So that was that's just that muscle memory. He'd been doing it for all his life in that home.
Exactly.
So it's
I mean, have you ever moved a clock from one part of your wall to another part of your wall, and for months you look at the wall and the clock? Oh, that's right, I moved the clock. I mean, I've done that.
And we're so if it's hard for us,
it's habitual, correct?
For sure.
Yeah. So. I'm really happy to see that you're giving them the tools that they need to succeed through dementia. It's really important that you're helping them like that. It makes my heart full when I hear that.
Yeah, it helps them just feel that independence, rather than me having to follow them around and correct them over and over.
Correcting is not wise, because like you said, they're not children. So we need to stop talking down to those living with dementia, baby talk, because they're not babies. And they've earned the right for us to show them respect and to talk to them like they're adults. And we need to start remembering that it's important. It's hard not to baby talk, but I don't know. Just they're not children. They're adult seniors living with dementia. We even have some early onset people with early onset dementia, right? Those in their 50s that develop dementia, or 60s that develop dementia as well. So we just need to keep that in mind. They're not kids, they're adults, and we need to treat them as adults. Everybody deserves to be treated with respect and dignity. And how are we going to do that?
Yeah. Well, I appreciate you coming out. You've given me a lot of really good information, stuff that I hadn't touched on before. So
thank you for having me.
I'm glad everybody, I've never heard of those therapies. So even though I was participating in some of them,
doing them,
I didn't know that was, know, an actual thing. So definitely look up, what was her name?
Naomi Field. F like Frank, EIL. She has a video. If you want, grab tissues. She has a video on YouTube that you can find. Just look up Naomi Field and Gladys on YouTube, Gladys. And this video will break you. Like I said, grab the tissues. It's a great video. And I loved that I was able to get my validation therapy certification through Naomi.
Yeah. So great. So if you definitely want to use your services, who you're with?
So I'm with Savior Hospice and Palliative Care. My name is Maureen, but everybody calls me Mo. My last name is Best. I can be reached at 602-565-9908. My email is mo at saviorhospice.org. You can find us. Of course, you can like us on Facebook.
Yes, I have it on my Facebook.
And you can just look us up under saviorhospice.org.
Yeah, that'd be a great service to use if you're going through this with your loved one.
Yeah, we have both palliative care and hospice. Not everybody needs hospice, but we do have an incredible palliative care program as well that I'd love to tell you about.
Yeah, so thank you again, everybody. Again, I'm Ciara with Welcome Family, and we'll see you next time.